today, and I'm grateful to the organisers for asking me to come down. The topic I was asked to talk about today was dysfunctional uterine bleeding, which is maybe a trap because we're not really supposed to use that term anymore, so I've changed to abnormal uterine bleeding. And dysfunctional uterine bleeding is a term we're probably all familiar with as a diagnosis of exclusion for anyone with abnormal bleeding, but it's no longer recommended terminology. So it's not quite projecting properly, but the FIGO Working Group on Menstrual Disorders produced a new classification system after a series of meetings in Washington and Cape Town, which must have been tough for them. So respect to them for that. And they've summarised the classification system in this document, which I would recommend you have a read of. And I've basically summarised the contents of this in this talk. It's worth just reflecting on the function of the endometrium. It's really quite a remarkable organ. Its function is to receive a blastocyst. We know it's sort of controlled by the hormones from the hypothalamus, the pituitary, and the ovarian axis, but it's a highly metabolically active organ. There are many hormones and local mediators involved in very complex processes within the endometrium, and remarkably, it completely regenerates without scarring every single month. Which, if other organs in the body could do that, it would be obviously to our benefit. Ray Gary's done some interesting work looking at the endometrium. I'm going to get a little bit darker just to see that better. And in this paper from 2010, he studied the menstrual endometrium and documented its appearance, which had never actually really been done before. And this is a picture on day 28 of the endometrium, and because of the intrauterine pressure, the sort of normal folds and thickness of the endometrium is sort of masked by the compression of the distension fluid. But you can sort of appreciate here, if you just drag the hysteroscope across the endometrium, how easily the stroma furrows, and you can get a sense of the depth and nature of the stroma overlying the basal layer. Coming up to menstruation, then you can then see how the endometrium begins to detach and is basically held on to the basal layer with a little pedicle of tissue. And then on day 1 of menstruation, after 24 hours of bleeding, the endometrium takes on this sort of appearance. And a closer inspection, what you start to appreciate is the variation within the endometrium. So it's not a uniform thing which is happening throughout the endometrium. There are islands of repair and degeneration, and in the lower part of the picture you can see a sort of a paler area of unshed endometrium, and right next to that an area of shedding endometrium, which is starting to detach and fall away. And when that happens, it sort of reveals a basal layer which has tubular structures, and on this picture you can hopefully appreciate just at the bottom half the tubular structures arising from the basal layer of the endometrium. And again, in this picture, they're sort of vertically orientated tubular areas just arising from the basal layer. When the pressure is slightly reduced from the hysteroscope, you can then see blood coming out of these tubes, which indicates that they're actually squeezing on these blood vessels. Again, in this day 3 picture, so after only day 3, the endometrium is now starting to regenerate, and again in areas there's islands of repair and islands of ongoing degeneration. And in this picture you can appreciate how already at day 3 there's new vascular patterns forming and blood vessels starting to grow, and just in the centre of the picture, bleeding from one of those highly coiled new blood vessels. And then in other areas at day 3 you'll see a thin new endometrium with an entirely new vascular pattern arising within it. So I mentioned at the start about the classification of abnormal uterine bleeding, and Why is it not acceptable to use a term such as dysfunctional uterine bleeding anymore? Well, a better classification is useful for research. If you're trying to study groups of women with bleeding disorders, it's helpful to have a well-defined system so that you're comparing like with like. If you're comparing two groups of treatment, for example, or treatment A against treatment B, a precise diagnosis will facilitate evaluation of the effectiveness of your diagnosis and your treatment. And it's certainly not a unique idea. Most other areas of gynecology use precise classification systems, such as staging for cancer or the POPQ system for pelvic organ prolapse. So this slide summarizes the PAM coin system. And PAM, P-A-L-M, basically encompasses the sort of structural or anatomical abnormalities or entities, whereas the other half, the coin section, contains the sort of non-structural or histological abnormalities. So I'd like to just go through the sections of the classification. So the P in PAM is for polyps, and we'll be familiar with these. These are epithelial proliferations which can arise from the endometrium or the endocervix. They can very often be asymptomatic, so they may not be causing any abnormal bleeding, and in rare cases can be malignant. This classification doesn't include polypoid appearing endometrium, which is thought to be a form of normality. The A stands for adenomyosis, and as you can see from the estimated prevalence of between 5 and 70%, the diagnosis of adenomyosis is very problematic. Ideally, it would be based on histological examination of the myometrium demonstrating endometrial glands and stroma within the myometrium, but there are other diagnostic criteria using ultrasound or MRI, the result being that the estimated prevalence can be very different depending on who's performing the test or interpreting the results. Its relationship to abnormal uterine bleeding is unclear, but again, looking forward and researching these disorders, it is helpful to have a defined group so that research can answer these questions. So L in PAM stands for leiomyomas, which I think we'll be hearing more about later. So fibroids or myomas are very variable in their size, their number and location, and these of course can also be asymptomatic, but it's thought that the submucosal myomas are most likely to contribute to abnormal uterine bleeding. And the system does encompass a sort of a sub-classification for classifying fibroids based on their location, and we're probably familiar with the submucosal classification of type 0, 1 and 2, depending on the extent of intramural involvement of the myomas, but they go a little bit further to look at the other types of fibroid which may have a serosal or endometrial or both component, and those can be classified according to the system, which I won't go through in detail, but is shown here. So the M in PAM stands for malignancy and hyperplasia, and if this is identified, it should be classified according to the relevant WHO or FAGO classification, and it's just included in the system for completeness. So the C in COIN stands for coagulation disorders, and it's been estimated that in fact that 13% of women with heavy menstrual bleeding have disorders such as von Willebrand's, and this can be screened for in the history, in particular looking for history of postpartum hemorrhage, epistaxis, bleeding with dental procedures, bruising, and that can help direct a patient towards hematological or further investigation of their coagulation. Anticoagulant use, many patients using things like warfarin for other medical disorders would also be included in this section. This is a screening tool which can be used for screening women for an underlying coagulation disorder, and Initial screening involves asking for any of the following, which is heavy menstrual bleeding since menarche, postpartum hemorrhage, any surgical related bleeding or bleeding associated with dental work, or two or more of the following symptoms, bruising, epistaxis, frequent gum bleeding, or family history. So ovulatory disorders would be much of the dysfunctional uterine bleeding group would be probably within this section, and this may present as anything from amenorrhea to extreme heavy menstrual bleeding, and is mostly linked to anovulatory cycles, particularly in the extremes of reproductive life. It can also be linked with endocrine dysfunction such as polycystic ovary syndrome, thyroid disturbance, hyperprolactinemia, obesity, and other disorders. So E is for endometrial abnormalities. So this is in women with ovulatory cycles and in which there is no other identifiable cause. Probably includes infection or inflammation such as chlamydia infection, but has been shown to be due to deficient production of vasoconstrictors or excessive plasminogen activator or vasodilators such as PGE2 and prostacyclin. These have been studied and have been shown to be highly relevant in endometrial bleeding, but currently tests are not available to identify these local abnormalities. So I in the system is the iatrogenic, which is things that we will do to patients, such as use of the Mirena, exogenous gonadal steroid use, but other medications such as anticonvulsants, antibiotics, and even cigarette smoking have been shown to cause abnormal or irregular bleeding. N is not yet classified, so these are entities that are currently poorly understood and not conclusively thought to be causes of abnormal uterine bleeding. These would be things like arteriovenous malformations, chronic endometritis, and myometrial hypertrophy. So just as an example then, if you have a patient, you wish to use this system, so for example, a patient with heavy menstrual bleeding, you find that she has anovulatory cycles, either based on history or mid-luteal phase progesterone. She might have a submucosal fibroid identified on scan or hysteroscopy. So she would be classified as AUB, L, and O. So in terms of investigating, it's recommended to consider investigating after 3 or more months of excessive duration, volume, frequency, or unpredictable abnormal bleeding. And the investigation should consist of a structured history, looking for evidence of ovulatory function, inquiring about future fertility plans, also identifying related medical disorders, medications, and lifestyle factors, but also considering screening for the coagulopathies. The physical examination will include a uterine evaluation, which I'm not going to talk about because that will be covered elsewhere, but also considering ancillary investigations such as a blood count and evaluating any endocrine disorders. So just a bit of recommended reading. The PAM-COIN classifications in a journal article by Monroe et al. In the International Journal of Obstetrics, Gynecology and Obstetrics from 2011. There's also a NICE guideline on management of heavy menstrual bleeding, and the Cochrane database of systematic reviews as well as a relevant article. Any questions?